All right, everyone. Thank you so much for being here. Welcome to Within Summit Day 2. Just as a reminder, we are going to be recording today's session live. And if you have any questions or comments that come up during today's session, just feel free to throw them in the chat. I will be monitoring the chat and we will get to those questions likely at the end of the session if we have time. So today I would love to introduce our moderator and our panelists for today's discussion. Today, our moderator is Ashlee Knight. She is the Senior Program Director at Project Heal. Ashlee believes that treatment and healing should be available to everyone and is passionate about removing barriers so that people have better access to the care they deserve. As a licensed mental health counselor and approved clinical supervisor in the state of Washington, Ashlee brings to the table 15 years in the nonprofit and mental health sector. Ashlee, thank you so much for joining us and being here today.
Yeah, absolutely.
We are also joined by Alexa Grayson. She is the Insurance Navigation Program Manager at Project Heal. Alexa is passionate about advocating for folks who struggle with eating disorders and removing barriers to reach accessible care. She wholeheartedly believes everyone deserves equal treatment and care and that healing is possible. Alexa joined Project Heal in 2020 as a national volunteer and later became insurance lead specialist for the Insurance Navigation Program. Alexa brought her experience in insurance and mental health to help Project Heal's directors develop and implement the Insurance Navigation Program. Alexa, thanks for joining us.
Yeah, thank you.
We also have with us Eunice Feng. She serves as the Treatment Access Program Manager at Project Heal. Eunice believes that equitable access to healthcare is vital to keeping QT BIPOC alive. Their values are deeply rooted in disability and transformative justice, and they hope to see the day when health insurance systems will no longer be profit-driven. They have supported folks who experience alternative realities and mental health diagnoses in varying capacities over the past 10 years and enjoy spending their free time doing mutual aid projects and eating good food with friends. Eunice, welcome. Thank you so much for being here.
Thank you.
And lastly, we are joined by Safiya and McHale. They serve as the Clinical Assessment Program Manager at Project Heal. Safiya is passionate about creating more equitable access to eating disorder care, and she believes that everyone deserves healing that affirms and celebrates the whole self, and that no one should have to compromise aspects of who they are to receive care. Safiya recognizes that people who hold multiple marginalized identities are often most impacted by barriers to healthcare access, and is personally invested in making mental health care safer and more accessible. Safiya, thank you for joining us. We are so excited to have you all today at Within Summit.
Thanks for having us.
Thank you.
And Ashlee, I will pass things over to you.
Yeah, thanks so much. So as you may or may not know, Project Heal, we exist to break down systemic healthcare and financial barriers to eating disorder healing. And we're really excited to share with you more about the work we do and what we believe that equity means in the eating disorder treatment landscape. So I'm excited to be moderating today, and we have an introduction from each of us, which is awesome, but I would love for Alexa, Safiya, and Eunice for you each to share a little bit more about what specifically brought you in your career trajectory to Project Heal. Kind of why did you land at Project Heal? Alexa, do you want to go first?
Sure. So I came to Project Heal. I started in the field after I got my license working with eating disorders, and I became really passionate about the work. I got out of the field after some time and wanted to find a way to get back in, and I came across Project Heal. I was actually a little bit I knew of Project Heal in my past, my own personal lived experience, and I was really excited to learn more. So I reached out actually and joined as a volunteer. As Kath mentioned before, and that's when we started kind of developing the insurance navigation program. And that's changed so much after the last few years. I was a volunteer for 2 years, and I have always been passionate about, I've wanted to make more of a systemic change. And I think that just my knowledge even grew when I joined Project Heal, and I became more passionate about that as well. Also really passionate about barriers with insurance, because as a clinician, I've learned so much of those barriers over the years and how many barriers exist in the eating disorder field. So I'm really passionate about working to do whatever I can to advocate for folks with those barriers.
Awesome. Thanks. Safiya, how did you land at Project Heal?
Yeah, I started in the eating disorder field shortly after I graduated with my MSW. I was doing mostly a lot of outpatient work with eating disorders, and I love clinical work so much. It is my heart and soul. And I also wanted to have a chance to work on some of these systemic issues that I was seeing come across so much in outpatient practice, and just so many people weren't even able to access outpatient treatment. So I heard through a friend actually that Project Heal was launching this clinical assessment program. We launched it in April. And the timing was just right, and it was an opportunity I was really excited about.
Well, Eunice, how about you?
Yeah, I think I'm the only person here without a eating disorder work background. I do have lived experience, but previous to Project Heal, I was working a lot just in the mental health field in general. And I kind of got sick and tired of it and was really wanting to work with an organization that really valued equity and was really, kind of doing real work in that regard and not just using it as a buzzword for funding or for promo. And so I found Project Heal, and that's just kind of how I landed here. So
awesome. Cool. Thank you. So could one of you or any of you explain how Project Heal fits into the larger eating disorder field, the treatment landscape? Where does it actually land in terms of why would people come to Project Heal versus going to a treatment center first, or a clinician? Can you explain that?
I can share a little bit about how people find their way to clinical assessments. I think a lot of people come to clinical assessments because either they don't have a diagnosis, they're unsure if they have an eating disorder, they might be struggling a little bit, but not sure. They might know they have an eating disorder, but they're not sure what level of care they need. Sometimes a clinician has recommended that they come in, or sometimes a clinician says, hey, you need to get an assessment before you get started. Sometimes people want a second opinion on a level of care that was given by a treatment center. So those are some of the ways that people frequently find their way to me.
Yeah.
I can speak regarding insurance navigation. I usually get past folks when they're coming from applying for treatment access, or maybe they are assessed by Safiya and get sent to me to then get set up for maybe a treatment center or providers. But insurance navigation, I really work with folks who either want to better understand their insurance benefits and coverage because they don't know what might be included. And I know it's hard to start seeking out treatment when you don't know what might be covered. I also work with folks sometimes to get insurance and enroll in insurance, Medicaid, or through the marketplace, which with open enrollment is coming soon to sign up for annual insurance. And I work with folks also in advocating towards insurance, maybe doing appeals if they don't have a certain benefit that was covered, if they were denied for maybe the residential level of care. I'll help folks kind of see what we can do to either fight that denial or see if there's anything else we can do to get them covered for the service that isn't usually covered.
Awesome.
I get a wide range of folks. Typically when people come to Project Heal, they're looking for some type of eating disorder care or support, or just like direction on where they should go, how their kids can get care. And so I'm kind of the person that does all the application reviews. I walk people through the process. And then once we get the application, I kind of direct folks to how we can best support them. Sometimes that leads to a placement with one of our program partners. Sometimes that leads to some amount of cash assistance. Sometimes it leads to a referral to Alexa or Safiya, or a referral out to other resources that we have.
Awesome. So what I think is kind of the common thread here is that folks usually are coming to Project Heal because the resources that they have on their own aren't working or aren't enough to get them the care that they need. Or in your case, Safiya, they they don't even have a diagnosis yet or have no idea what kind of treatment that they would need. So we're the stop that happens for folks when what they need isn't happening and what they have isn't working for them to get the treatment and the care that they're looking for. So thank you all for sharing about that. So we're throwing out this equity word a lot, and the whole, the topic of this conversation is, around equity. How would we define it at Project Heal? I think it's a word that can be a buzzword. And like you said, Eunice, like you're familiar with organizations that use the word a lot, but don't actually put it into practice. And so I'm curious from each of your perspectives, how are we embodying equity in the work that we do, and what does that mean for us? Would love to hear from each of you. If you can.
So I guess I can start and speak to it a little bit. I feel like, most folks are familiar with the term equity and thinking about how, we've all seen like, well, maybe not everyone, but there's a graphic of like a fence and then three different height people standing on the fence, and how equity is making sure that everyone's maybe line of sight is around the same height versus everyone has the same equal like stepping stone. And then there's kind of this new one where the fence completely breaks down, where like you break the whole system, right? And I think that's kind of the image of equity that I have in my head when I think about it. But also I think other aspects of equity, especially on our end as like providers or people trying to provide care to folks, that it is like understanding that there's it's a long process. It's not something that happens in an instant. We're allowed to make mistakes in this process, and it takes a lot of steps to work towards it. I think as a whole, as long as we're like working our way towards equity, there's not like one single destination. There's so many aspects of like of care and identities and different things that people need, that people historically have not been able to get met, that it's not like one singular event. And then also just like equity is also just awareness of where we as providers and people that work in the field, and also where our clients stand in terms of like positionalities of power and just awareness in general. And then I think I want to like emphasize that it's equity to me and to all of us, I think, is not simply just an inversion of the existing hierarchy, and that equity is also not offering the same structure of support to every person free of cost, right? Like equity is much more than that. It's much more nuanced, and doing those two things kind of doesn't necessarily challenge the system that we have in place, and also perpetuates it. And so I just want to kind of how I think about equity.
Awesome, thank you.
That was such a great definition and description, Eunice. I actually don't have anything to add to it. I think that encompasses a lot of what we do and our viewpoints and values just really well.
Yeah, I agree, not to join the trade, but I think you really discussed everything that equity kind of embodies for us. And, for me, especially in the insurance sector of things, what you said that kind of really struck with me was the awareness. I think I work with folks a lot, providers, but especially folks at insurance companies who I end up speaking to who really don't kind of have that awareness or education of what that looks like, especially when it comes to like Medicare or Medicaid, which I work with a lot of folks on most commonly. So I think that's super important when it comes to equity.
Absolutely. And Alexa, I think we'll be hearing more about that in just a little bit. So Eunice, I want to go into more detail with each of you around the I can never say specificities around your particular role. And so Eunice, as you're working with folks who are, you're the treatment access part of our programming. So you're doing direct placements with folks, with providers. And we'll also talk more about ways that we partner with providers specifically towards later in the call. But when you're, making these provider connections and working with like-minded clinicians who want to make sure that they're embodying an equitable practice, what are some factors to consider for providers to consider when deciding how to incorporate equity into their practice?
Yeah, thanks for the question. I want to preface by saying, I certainly don't have the end-all be-all to this question. It's a really big question. But there are certain things that come to mind in regards to my the work that I am doing with Project Heal. I think it's really important when I'm doing the work that I do to consider, one, my capacity, my biases, and also the network that I have around myself. And so something that I think about is are you a queer BIPOC provider and you have a chronic health condition and you have 5 senior rescue cats that you're trying to take care of? Rest is a very important equity informed practice, and I really encourage that in all providers. If you're interested in making sure that equity is a practice that is manifesting in the work that you do, rest, right? And then on kind of the other end of the spectrum, if you're a provider who doesn't hold a lot of systemically marginalized identities, but you're really busy and you have a ton of out-of-pocket clients and you're promoting your practice and you have a new book out and you have 5 podcasts that you need to record in the next 5 hours, again, rest is a very equity informed practice, and it's okay to slow down and reassess and think about your work and how your work fits into the equity framework that you want to practice. Another thing is just, I think, giving yourself space to be uncomfortable in spaces that you usually feel pretty comfortable. I think a lot of eating disorder providers are very well versed in what they know, which is great and amazing, and we need that always. And also, I think adding another layer to that, trying to connect with intersections of the eating disorder world that are less visible. And so, something that I saw recently from Nalgona Positivity is dating while fat and in an active eating disorder. That's really important. Eating disorder in different religious communities, any kind of anything that kind of pushes the boundaries of what we know, either clinically or sociologically, I think is super, super important. And then I think lastly is considering the network that we have, taking a moment to see who is in our network, either professionally or in our personal lives, and how that reflects the types of connections that you want to foster in this type of work, I think is really important. And having that kind of personal connection to different types of narratives is important to incorporate equity. So.
Thank you. Safiya, how does the clinical assessment program specifically work to improve equity in the eating disorder treatment world?
Yeah, so I think there's a couple different ways. Firstly, our clinical assessment program is free. It doesn't require insurance or anything like that either. It's pretty low barrier in terms of signing up, things like that. We just meet via Zoom to do an assessment that can take between I'd say between 45 and 65 minutes about. We can do it by phone also, so it's no cost in terms of anything that they're paying us, and the barrier is pretty low. And so by being free and by kind of working on breaking down this financial barrier, we're able to access a lot of people who traditionally wouldn't have access to getting eating disorder care, treatment, things like that. Eating disorder assessments are really expensive. They can be $250 plus. A lot of eating disorder clinicians don't take insurance. A lot of eating disorder clinicians will have people do several sessions before they provide an assessment and diagnosis. And all of that is great and valid and a certain way to do things, but it also leaves out a lot of people who aren't able to access that or who don't have insurance, different things like that. So I think we're able to get a lot of people in the door. We have a pretty high percentage of people who are BIPOC, who apply for and go through with the assessment. And then most of the people that I see, I end up referring to Alexa for insurance navigation, or to Eunice for treatment access support. So you're kind of getting access to a lot of the different services that Project Heal is able to provide and able to support people with. We do a lot of internal referrals. So I think by being free, we're able to get people who don't traditionally have that access to have a little bit more access.
Absolutely. And what, from your perspective, are the ways that most people are finding out about the free assessments?
A lot of people find out by Instagram or TikTok, which kind of surprised me, but I think that's
Made it to TikTok?
That's amazing. Yeah. A lot of people, it's Instagram or TikTok. Some people, there's a lot of like word of mouth. So sometimes it'll be like, I saw it, I was at like a treatment center for something completely different, and like a friend of a friend mentioned Project Heal. So yeah, a lot of word of mouth, a lot of social media.
Awesome. Alexa, so you've talked frequently in this call too about the barriers that exist within insurance. And I think that anyone in this chat room and anyone that has worked with eating disorders at all in a professional capacity understands that insurance is probably the primary barrier to for people getting the care that they need. But what specifically, if you break that down a little bit, what are the specifics that you see around that? And can you speak to, just what you notice?
Yeah, absolutely. There are so many more barriers than I would like to really be able to admit, but we see them so often. And I think Safiya mentioned it as well. Just, I get so many folks coming over to me who have completed their clinical assessment. And as I mentioned before, I work with a lot of folks who do have public health plans such as Medicaid or Medicare. And those plans don't have really the benefits for a lot of different levels of care. Medicare itself, just for folks who need, when you're healing from an eating disorder, a lot of folks need to work with an outpatient team. So that might look like a psychiatrist, a therapist, a dietitian, a primary care physician. A lot of folks don't have. And we want to connect them with folks and providers who are experienced working with eating disorders, who have that knowledge, sometimes who have shared identities. As Safiya mentioned, we are working with a lot of folks who are BIPOC or identify as queer. And honestly, it's sometimes hard to find providers who share those identities and who are eating disorder informed and trauma informed. And those who, do kind of fit those niches or those identities might not take insurance because it's so hard to get paneled with insurance, or it's hard to get those services covered. Medicare itself doesn't provide dietitians or nutritionists for eating disorder diagnoses. So, while Safiya mentioned an eating disorder diagnosis is so important with insurance, it's true. And in some situations, it even keeps us from getting covered, which is frustrating. With Medicare itself, you can only get a dietitian or nutritionist currently if you have a diagnosis of diabetes or kidney issues or something usually in that area. So typically, we can't find coverage for a dietitian under insurance with an eating disorder. And as I'm working more with beneficiaries, I'm seeing other insurance companies, Medicaids, even some private insurance that is starting to report they're not covering nutrition for eating disorders either. They're only doing it for, certain medical complaints of issues with your kidneys or diabetes or something, that they label as a chronic medical condition. So that's really tough. We do a lot of advocating with that, but, with certain companies such as Medicare, there's not much that can be done at this point, which is where the awareness comes in. So I think that's a big gap. Another gap is, I've mentioned Medicare and Medicaid a lot, and I think that's where a lot of the barriers unfortunately come, and where so many people, that's how they are covered. Medicare covers inpatient and outpatient. it typically doesn't cover those in-between levels of care, such as IOP or PHP or residential. Some Medicare plans will cover PHP or IOP, but it's pretty limited. They're usually out of state, can't be done virtually because Medicare typically won't cover it. And those programs that are offered are very hospital-based. Some of them are, but a lot of them are not held at every size. Some of them are very specific in that treat anorexia and bulimia diagnoses, but not, maybe other specified eating disorder or ARFID or binge eating disorder. And those are the most common eating disorders that I think are prevalent in the field. So that's really tough with a lot of insurance companies. And I could go on about this list, but I think another big one that I see is, even for folks who do have that coverage, medical necessity is a pretty frustrating thing where you need to meet a specific criteria in the eyes of insurance to be approved for that level of care, even if your insurance does cover it. So I think this is most common in the residential level of care. And again, with folks who, might have that anorexia or bulimia diagnoses. I've seen some insurance companies who are still following criteria from the DSM-4, even though we're on the DSM-5 now. So they're following criteria that, anorexia is a little bit more cookie cutter. You have to be under a certain BMI, or, BMI is a big thing that keeps a lot of folks from getting covered. ARFID also was not in the DSM-4. So some insurance companies, I'm told, they don't know what ARFID is. They don't cover it. And also for folks who are in larger bodies, binge eating disorder can be tough to get covered in residential. And I've done a lot of appeals and advocating against that. So that's a big thing. And just overall, there's a lack of education and a knowledge gap with a lot of the insurance companies that I talk to. So I think that's the biggest thing right now to be aware of, and the biggest barrier that kind of overall links everything.
Yeah, I'm just pretty stunned. Like I we're in this work every day, and I think that it's I know this information, and just hearing you reiterate all of the layers and the complexities that exist within the insurance system is like, it kind of takes my breath away every time I hear you talk about it, because it's atrocious, like how failed people are by what is seemingly to exist to help people get the care that they need, and how it actually just works against them instead. And yeah, it's a very broken system. Thank you
Absolutely.
for sharing that, Alexa.
Thank you.
Yeah, Eunice, so back to treatment access. So when you were trying to provide treatment access to folks, whether it's through direct placements, cash assistance, whatever it may be, what are some barriers that you tend to run up against when you're trying to distribute treatment access in an equitable way? And maybe even, Eunice, can you give a little bit of context for folks on the call too about how even like our application process works, and when folks are seeking treatment access, what would the step be to even get that?
Yeah, so we have kind of a two-step application process. You submit a form requesting assistance, and then you submit you do a second step and kind of submit more forms on what kind of, providing more information on what kind of treatment you're looking for, what your financial access looks like, what your providers look like, what insurance you have. And then once a month, we review these applications, and then we go ahead and see what types of resources we are able to offer, what types we can't, and how, what other resources outside of Project Heal we can send people to. That said, I would say the primary barrier for us in providing equitable treatment is a lack of resources. No one is surprised. We're actually a very small nonprofit, and we don't, we don't bill insurance. We fundraise all of our funds, and so, as much as we would like to kind of end all of the oppressive forces that are working against folks trying to get eating disorder care, we're all kind of, unfortunately, kind of cogs in the same machine. And that's not to say that we're enabling the machine, and we're all just kind of we've all just kind of inherited and have to passively kind of participate in these enormous structures that are kind of passed down to us. Like Alexa was saying earlier, the American healthcare system, access to Medicare, Medicaid. In some states, if you're low income, that's not enough of a qualifier to get Medicaid. And then even if you do have insurance, access, like getting into the medical industrial complex is really complicated. There's so much racism and classism and that phobia. And we as a small organization often don't have the resources to provide um, to remedy that and to, you know, to provide justice and provide the care that every person needs. And to be honest, we usually end up not having the right kinds of resources for folks that need kind of what we think of as like the most amount of care. We don't have access to those types of resources, unfortunately, right? And so I think
Can you
again,
give an example of that? Like something that we would see that we just aren't able to provide the resources that someone would need?
yeah, I think Alexa might be also familiar with situations like this, but people who have Medicare and Medicaid, again, you know, if it's like people who have two health insurance plans, you think a lot of things would be covered, but it actually prevents you from getting into certain levels of care. People who have met their lifetime limit through their insurance, so you know, after 30 days of care, you're not allowed to have an eating disorder anymore, right? People who are undocumented, people who are houseless, um, and don't have access to consistent Wi-Fi for virtual care. There's a lot of, you know, like monolingual families, a lot of situations we run into that like we want to provide care, but people just don't even have the resources to get to the point where they're accessing that kind of care too. Um, I guess the only other thing that I wanted to bring up too in terms of barriers is kind of like reflective of myself, and I think um, these two things kind of go together, but one, a false sense of urgency, and then second, conflating equity with saviorism. Um, I think urgency is like very real. People need help immediately, and also as a reminder for providers and, you know, workers in the field like us, that saviorism kind of serves as a white neo-colonial function, and that again, I think to really embody equity, we do need to prioritize rest and wellness for ourselves, um, and also the idea that like we do have the power to save every person that comes our way is really harmful. And that's not to say that we don't want to try our best. But I think also again, like we're working up against such big, powerful systems that so many providers in this field burn out really quickly, right? Like I've burnt out a handful of times in my in my career in mental health. So just I think a reminder for folks to um, prioritize equity in the form of like sustainability, rest, wellness, what we would advocate for our clients and the people we work with.
That's really beautifully said, Eunice. I have some follow-up questions with that, but we'll keep going. I'll come back to that. But thank you for sharing all of that. And I think that what already we're each speaking to, or you're each speaking to, is just the complexity involved here. And obviously, as you said, like when we are up against like systemic structures that have been in place for so long, you know, we're digging our tunnel through, but we're still up against so much. And so thank you for naming a lot of that and putting language to it. What I think so many of us feel on a daily basis doing this work. Safiya, so with clinical assessments, you had talked about kind of why, you know, obviously the main point of having the clinical assessment program is to offer the opportunity for more folks to have a diagnosis in order to seek the treatment that they need. But can you speak a little bit more to why having a diagnosis is so important?
Absolutely. And this is another really complex issue. And I think that diagnoses can be such a double-edged sword. a lot of people find diagnoses to be really supportive and helpful in helping them understand what's going on, connecting with groups or people who are dealing with similar things, especially people who might not have had access to eating disorder treatment or language before and are kind of able to understand that they're not alone, understand that other people are going through similar things. Some people find it really unhelpful and feels like it boxes them in or feels like it excludes them. And as we were just talking about, it oftentimes really does exclude them. Like, for example, with providers going off of like weight for access to treatment for anorexia or binge eating disorder and things like that. It can be really exclusionary. I think that, working within a diagnostic system is inherently working under white supremacy in a lot of ways. When I was doing outpatient treatment for eating disorders, I actually didn't use the language of diagnoses too much, or even necessarily language about eating disorders. That doesn't always resonate with folks. Sometimes we prefer to talk about it in terms of a lens of like disrupted relationship to food in your body, because eating disorders can change and do change so much. Behaviors can change, people's bodies change. It's not a static thing. It's not this like static perfect box that I think the DSM likes to pretend it is. But regardless of all of those things, people still do need a diagnosis if they want to get treatment at a higher level of care. And again, that's so unfortunate when some eating disorders are taken more seriously than others, when insurance is more likely to cover treatment for some diagnoses. A lot of treatment providers specialize in treating some types of eating disorder over others, which of course we don't want somebody who doesn't treat anorexia in higher weight bodies to be treating anorexia in somebody who's at a higher weight. So things like that can just be really important to be aware of when we're making placements and things like that. But I think that fundamentally it's a middle ground of helping people being able to access treatment at a higher level of care as best as we can. And it's just not a perfect system. It never will be, as long as we're working under the DSM, as long as the healthcare industry is profit driven, as long as people are still using weight as measures of eating disorders and things like that. It'll just never be perfect. Diagnosing will never be perfect. It causes harm, and it also allows people to access treatment. So it's one of those really tricky double-edged swords that we have to sit with.
Absolutely. Very well said. And I'm curious if you could give an example. I know that you have come across this in your work with clinical assessments, but would you be able to give an example of a time where you've been on a call doing an assessment with someone and they are expressing to you that an actual diagnosis could feel more harmful to them, but they know that they need the assessment and they know they need treatment? Can you kind of speak to how you handle those conversations with folks?
Yeah, it's really individualized, and I think it depends on what people are needing, what level of care they're needing, what kind of support they already have around them. So one example I can think of recently was where an assessee didn't want to know their diagnosis, didn't want to know the level of care recommendation, but we were able to connect with their therapist and convey that information to their therapist instead. And this person didn't want to go to a higher level of care anyway, so it wasn't important in that way. So we don't do things that are unnecessary. Like, we would never want to give a diagnosis if it's harmful, not a supportive thing, not something that somebody needs. And we were just able to convey the findings to that person's therapist. So that's something that we can do a lot of times, for example, if somebody has outside support or an outside care team.
Absolutely. Awesome. Thank you. Alexa, so I know that you spoke a lot to what is very difficult with working with insurance and the massive barriers that we're facing, that our beneficiaries, our applicants are facing in navigating their current coverage. But what do you find that you are most often able to support with folks who are seeking you for insurance navigation support?
I think that the biggest thing that I will work with folks on is just really figuring out how to access care, whether that is outpatient providers. A lot of folks don't really know where to start, how to find providers with shared identities, or even, how to find providers who are trauma informed and experience working with eating disorders, and how do you distinguish between someone who kind of puts on their website that, I work with eating disorders and I am, more of like someone who really primarily focuses on working with eating disorders and is eating disorder informed. So I think helping folks navigate how to connect with those providers. Also, kind of as Safiya mentioned, helping folks ultimately figure out how to access higher levels of care. I will speak with a lot of people who really are coming to us, as everybody mentioned, when their other resources have failed them. And getting into a higher level of care is really difficult. And at the point that I speak with them, a lot of folks are really looking for residential level of care because of, having certain benefits or having Medicaid. A lot of folks don't have benefits for residential level of care, especially. So I think that's what I see the most often, is working with those who are looking for an eating disorder specific residential level of care. So helping folks figure out what that might look like, where that could be. And then a lot of times for those who don't have the benefits for residential, helping them learn about what a single case agreement is, if they don't already know, and how, like, what are the steps and how do you advocate for that within a Medicaid plan, especially. So,
and would you be able to explain what a single case agreement is, just in case anyone doesn't know?
Yeah, absolutely. So a single case agreement is essentially like a one-time agreement or contract between an insurance company and a treatment facility or a provider. And a lot of Medicaid private plans will offer this. Medicare typically will not do a single case agreement because they're federally accepted. But typically it is connecting with insurance, usually having to get a case manager assigned to you in behavioral health, if that exists within the plan, and just helping navigate with them and advocate for, is a single case agreement even possible? Because in most cases, especially with Medicaid, there aren't eating disorder specific, especially residential, in those states, or those that are really, if those do exist, those that, are a fit for that individual, or would it be more harmful? So figuring out, how do we get this one-time agreement for one, insurance to agree, and then we have to find a treatment facility who's willing to agree, which is even tougher when it comes to Medicaid. So just figuring out how to get all those pieces put together, and can we get this approved for a one-time for something that insurance typically doesn't cover, to agree to cover it this one time. And that can be a process. It can take several weeks. I've worked with folks who it's taken several months, and often it is successful, sometimes it's not. But I think that's the work that I'm most often doing with folks.
Awesome. Cool. Thank you. Eunice, kind of a similar question for you. So we've talked about kind of the treatment access needs that people have that are that we exist with limitations around as well. But how can you speak to kind of the treatment access support that we do have and can offer, and how that can support people getting the care that they need, even when, or even if, I guess, what the fullness of what they need, our resources are too limited to provide. But can you speak a little bit to how we can creatively work with them to help them get care?
Yeah, I mean, I guess, are you asking specifically in terms of like what Project Heal can offer?
Yeah, I think so.
Yeah, I mean, Project Heal, so we have, under the treatment access programs, there's kind of two different types of ways that we support. So Project Heal works with what we call the Healer Circle, which is a network of providers that have decided to partner with us and are able to offer sliding scale to pro bono placements with clients that we do have applications for. And so sometimes we have, we'll have therapists, we'll have dietitians, we have coaches, we have people who do yoga, acupuncture. And so, certain people who qualify for those types of placements, we do try to place. And then we do have a cash assistance program as well. This is mostly for, I think this is maybe helpful to clarify. A lot of people come to us asking for like $80,000 for a residential placement, and our cash assistance primarily is actually for folks who do have some sort of insurance coverage for treatment, but are not able to access that care because they have a high deductible or out-of-pocket maximum they can't afford, or any like co-pays, things like that, where it's within reach but not enough, right? So for folks who don't have insurance coverage, or have insurance coverage but doesn't cover any kind of residential, we actually direct them to our treatment placement program. And then for our cash assistance, also something that we pay for is like transportation costs, any tertiary costs that will get the person into treatment, or any costs that might prevent someone from getting into treatment. We've paid for just like a variety of different things, like we've made rental assistance payments, we've paid for pet care, we actually paid for a car to get repaired so someone can go to PHP, so there's a wide range of things that we try as much as possible to provide for folks that are coming through.
Yeah. Looking at the actual individualized barriers that exist in someone's life to getting where they need to be. Yeah.
Right.
Really awesome. Thank you. Okay, I have just a couple of more questions, and then we want to have a little bit of time if there's any Q&A from the room. But Safiya, I would love, you spoke to this a little bit around, some of the ways that a diagnosis can kind of not be the most helpful for someone, but also necessary for getting into a higher level of care. But how the kind of term that comes to mind with that is harm reduction. And can you speak a little bit specifically to how you see harm reduction playing a part in your specific role with clinical assessments? It's a huge question, but if you can distill it down.
Yes, it is a huge question.
Yeah.
So I'll talk a little bit about what I see the most. So something I see a lot is people who have a lot of treatment trauma, people who have been harmed by treatment, people who just wouldn't be particularly well served by the current treatment models that we have, and aren't willing to or able to go to a higher level of care, even when it's clinically indicated. So for the level of care, we can get pretty creative with our suggestions. I'll always include what an ideal situation would be clinically, but we can also provide some other options, brainstorm some other options as well. We would so much rather somebody get some treatment rather than no treatment because a certain level of care has harmed them in the past. So for example, sometimes, somebody might have a dietitian and a therapist, and maybe like the next step is adding in a coach and some support groups. Maybe it's adding in a physician and working with a physician and dietitian to get repeat labs as they're kind of working on outpatient treatment to make sure that they're as medically stable as possible while they remain in a lower level of care. Sometimes it might be something like helping somebody get connected with a psych trauma program rather than an eating disorder program if, both are indicated, but somebody, has experienced a lot of harm at eating disorder treatment centers. Sometimes it's helping people incorporate like a peer support person onto their treatment team who's able to advocate for them. So a lot of it is just listening to what are the barriers that this person is facing, what are the ways that they've been harmed, and how can we help fill in some of that gap. It usually won't be all of the gap, but we can at least provide some support, especially when it comes to medical stability, like just the information about like labs, risk, things like that, and connecting them hopefully sometimes with providers who are willing to work with people who might benefit from a higher level of care, but aren't able to or don't want to access that. So it's a lot, just like a lot of like listening to people's needs, hearing what the barriers are, and rather than being another voice that says like, oh, okay, so you won't go to residential care, that means we won't treat you, that means we can't help you, we won't help you get access to anything. Rather than doing that, we say, okay, so what do we have, what could be beneficial? There's a lot of free groups, free support groups that people might not know about. A lot of people don't know about the option of coaching. Sometimes adding in meal support is something that's really helpful. So we can just kind of talk to people about what various options are, what sounds good to them, and where can we help get them connected to that. And also sometimes it just helps for them to see that option written on a clinical document where they can take that to a therapist or dietitian, can help provide a little bit of reassurance to a treatment team as well, that somebody does have options other than a higher level of care.
Thank you so much. Really helpful. Alexa, the last question for you. You said that you were doing some advocacy work and some appeal work. Can you speak a little bit more to the Mental Health Parity and Addiction Equity Act and your involvement with that?
Sure, absolutely. So for those who aren't familiar with this act, it was passed in 2008, and it's a federal law that exists for requiring group health plans to have equal access of benefits for what is given for medical benefits to also to mental health. So that has been something that has given a little bit more access in the field, but I think actually what I see is a little bit more of, again, the barriers. What comes to that too is that this act, it does, so it covers how it's written, it is mental health and substance use, but there's nothing eating disorder specific. So I think a lot of times when I'll work with plans, like I spoke about with Medicaid, when they are required to offer something in state under the plan that falls into this category, they give referrals and it's usually mental health or substance abuse, but nothing that specifically covers for an eating disorder. So I think that's been a big barrier too. I think one of the big things that I'm working in advocacy with is just to make others aware of kind of what's not included in this act, though it has been helpful. And a lot of insurance companies I've found too, especially Medicaid, doesn't always kind of follow that, like I spoke about before, when there are limitations with nutritionists where they'll cover it for medical diagnoses but not as much for eating disorder diagnoses. There was an act, the Mental Health Matters Act, that was passed recently, which kind of reinforces this parity and starting to give, I think, penalties for insurance companies who don't follow that. So I feel like we're getting further in the field in this area of advocacy, though something that I would love to see more is just more of that eating disorder specific language. And that's a lot of why, Medicare and Medicaid will provide hospital-based services, because when you're getting medical issues treated, it's usually in a hospital. So that's why, like inpatient, some partial levels of care, it'll usually be a hospital-based program, which isn't always, the right fit for folks. So yeah, I think it's just, that's an area that I would love to advocate in more and just see grow even more.
Thank you. Thanks for sharing that. We have just a few minutes left. Do either or any of the three of you have anything that you didn't speak to that you feel like you would want to mention before we're wrapping up the call?
I think one thing that I want to name is just how complex this work is, how tricky it is to work within a system that is like inherently has oppression, white supremacy ties to it, and still try to help people get the care they need, get access to benefits that they deserve. One thing that I tell people all the time is like, you deserve the same care and treatment that a thin, white, 18-year-old woman, cis woman with anorexia gets. Like, you absolutely deserve that. And we cannot invent treatment options that don't exist. We can't, will into existence new laws or things like that. So I think one thing that I sit with a lot is just the complexity of what we do, how challenging it is, and how we just have to remember that we are not genies. We are not able to just conjure up options that don't exist, but what we can do is be creative and resourceful.
Absolutely.
Yeah, I want to piggyback. Oh, sorry. Go ahead, Ashlee. I was just going to piggyback off of what Safiya said. I think that's like so important to just acknowledge that how complex the work is. I think sometimes it's not helpful to. Sometimes it's not so helpful to act like we live in a world that we want to. It's sometimes more realistic to just to acknowledge that the world we want is not the world that we have, and to kind of like navigate the resources we have accordingly. Like so many things that are not real, like race, the DSM, like these things aren't real, but we've made it real. And so it's like in our world and we have to navigate these things. And I think, one thing that we do have is like this shared community of people that want to do better for folks in this field. And so I value that a lot.
Absolutely. Yeah. And that's what I was going to say is I think that a way to kind of work within the very complex limiting system that we're in is to continue growing our network of people committed to doing equitable work. And so if you're a provider on this call and this has been resonating with you and you weren't aware of Project Heal before, or you were, but want to kind of partner with us more to help grow our provider network, seeking to make treatment more accessible to folks, we would love to work with you. And so I'll make sure that we drop our emails, or Kathy, you can get our emails to folks. But yeah, the more people doing this work, the better. And I know we have 2 questions in the chat. Do we have a few more minutes, Kath, to speak to some of these questions?
Yeah, absolutely. I think we have like 4 or 5 minutes left. So
okay,
go ahead.
Awesome. So the first question from Lacey, how do we reconcile personal frustration with so many barriers in the system we have to work within stopping people from getting the help they need? So I think I'm hearing that as when people are facing so many barriers and the personal frustration that comes from that, using that as a reason to just kind of give up or quit trying to seek care. Can any of you speak to that for a moment?
I can touch on that. I think one thing that Eunice touched on that was so important was the importance of rest and sustainability in a practice like this. So I think reminding myself that I can't do it all, that's just not possible. And the work that I'm doing is not really all that radical or revolutionary if it's not sustainable, if I can't keep it up. So I think that's really important. Another thing that I do is I save all the emails that I get from people who we have been able to help, who report on their situation a couple months later, a few weeks down the road, things like that. We get a lot of really, really kind emails. And so I have a folder that just reminds me that we are able to do a lot of things. And I think sometimes looking at it, even like from a harm reduction standpoint sometimes, or looking at it from a lens of what were we able to do? Because we were able to do some amazing things. There's a lot of things that we couldn't do, and there's a lot of really great things that we could do. So I think keeping that someplace that's easily accessible and making sure that I'm going at a pace that feels sustainable to me has been really important.
Yeah. Anything that any of you would say to someone like a client themselves who's frustrated with getting the care to, like, I love that perspective, Safiya, for the provider from the client standpoint, when someone just keeps getting met with no's, anything you've been able to share with folks to kind of help keep them working towards their healing, even when they're facing insurmountable barriers?
Yeah, I think one thing that can be really helpful is getting people connected with community. So I know there's a lot of like support groups, things like that. There's like a lot of support groups specifically for trans or gender nonconforming folks. There's a lot of resources for group support for people who are BIPOC, who have eating disorders. So I think like sometimes connecting people to other people who have shared struggles can be very helpful. And sometimes just like validating and affirming that this is really hard and there are very real barriers. There's so many systemic barriers in somebody's way, and just kind of affirming and supporting that it's not all in their head. Like, this is real. This is very hard. This is very difficult. And then connecting them with some peer support if possible.
I love that. Eunice or Alexa, anything else to add there?
Yeah, I just want to piggyback off of what Safiya said, that I think that, my own personal struggle, I think sometimes is just when I recognize that there might not be anything that I can do to help with the resources that folks do have. So I think what helps me with that is, like Safiya said, connecting folks within certain communities. I definitely give a lot of referrals to free online support groups that folks can join within their community with shared identities of different ages and things like that. I think that's been super helpful. I also find, kind of like Safiya said, that similar to like the therapeutic relationship, building rapport can be so much of the healing. And I think that when I do have conversation with folks where, you know, instead of saying there's nothing that we can do, giving that validation and, you know, bringing to awareness of what that situation really does look like, there's a lot of healing in that awareness and that conversation, I think. And I do have emails of folks that say, you know, even though we couldn't access what I was looking for, just having been acknowledged that this is happening and talking to someone about it has been so helpful for me. And it does give me a reason to keep holding on to hope and going forward in my recovery. So I think those conversations even are just have been so helpful and so important for folks.
I know we're out of time. Heather, I'm sorry we didn't get to your question, but I'm going to copy and paste it, but you're welcome to email one of us. We'd love to follow up with you as well to make sure that we can speak to some of what you're asking as well. But thank you all so much. And Safiya, Alexa, and Eunice, thank you for just the work that I know you're doing every day that I get of like front row view, watching you all just doing incredible work. So thank you so much for your wisdom that you brought today and for the work you're doing on behalf of folks who are so deserving of care. So thank you.
Thank you all so much for being here today. This was such just a wonderful and insightful conversation, and we really appreciate you all taking the time to be here with us at Within Summit.
Thank you.
Thank you so much for having us.
Thank you.
Everybody enjoy the rest of your day.